Hello, everyone, and thank you for joining us today. I'm Zobair Younossi. On behalf of CME Outfitter, I'd like to welcome you on this CME activity titled Getting Closer to Targeted Therapies for NASH. Are you ready? Today's activity is supported by an educational grant from Novo Nordisk, and the activity is brought to you by the CME Outfitters, an award-winning accredited provider for continuing education for clinicians worldwide. I want to encourage every one of you to join us in our live Twitter conversation today. We will be monitoring the Twitter feed and responding to your tweets throughout the program. Again, I'm Zobair Younossi. I'm the chairman of the Department of Medicine, as well as the professor of medicine at Nova Fairfax Hospital in Fallsville, Virginia. I'm also the president of Nova Medicine in the same institution. I'm very pleased to be joined by two distinguished colleagues that you know very well. First, let me introduce Dr. Rohit Loomba, who's the director of the NAFLD Research Center, professor of medicine, director of hepatology, and vice chief in the division of gastroenterology, and adjunct professor in the division of epidemiology of University of California in San Diego. Welcome, Rohit.
Thank you, Zobair. Delighted to be here. Really looking forward to an exciting session, and we have a great team here. Super excited.
Thanks, Rohit. Glad you're here with us. Next, let me also introduce you, Dr. Mazen Noureddin, who is the director of Fatty Liver Program and the CARSH Division of Gastroenterology and Hepatology with the Comprehensive Transplant Center at Cedars-Sinai in Los Angeles. Mazen, welcome.
Good evening, Zobair. It's 80 degrees here. You guys were supposed to be in Southern California, but it's okay. I'm glad you guys are safe, and hopefully we'll see each other next year.
Thanks, Mazen. Great to have both of you. And let me just now start by giving you sort of an overview and set the stage about unrecognized epidemic, actually pandemic of NAFLD and NASH, because it really is a global phenomenon. So before actually we start with bioepidemiology, let me just remind you about how to define NAFLD. NAFLD is really an umbrella term that includes NASH as well as just other types of fatty liver disease that don't fulfill the criteria for histologic diagnosis of steatohepatitis, which requires at least having 5% of hepatocytes having fat, in addition to evidence of ballooning of hepatocytes in some miliary bodies if you see them, or pericell fibrosis. That's a diagnosis of steatohepatitis. NAFLD just requires having fat, and all of these, the spectrum requires exclusion of other causes of chronic liver disease, including excessive alcohol use. Now, when you look at the global prevalence of NAFLD, this is from a meta-analysis that we performed a few years ago. The global prevalence of NAFLD is about 25%. With the highest prevalence in the Middle East, and actually now potentially is even in North Africa, very high prevalence rates. When you look at diabetics, the prevalence is higher; it's about 55%, and again, very high prevalence rates, and again in Middle East and South America. Now, when looking at pediatric NAFLD, the prevalence is about 7.5% or so. The prevalence in South America is about 25% and pediatric population. And when you look at these prevalence rates over time, not only these are very high prevalence rates, but they're also increasing in most regions of the world. Now, when you look at the prevalence of steatohepatitis, non-alcoholic steatohepatitis, obviously you cannot biopsy general population, so you have to estimate that. That prevalence in general population is about 1.5 to 6.5%. But again, when you come to the individuals who have type 2 diabetes, the prevalence of NASH is about 37%. Now, looking at all of these and putting some numbers in terms of what we are looking at. So, of course, the majority of patients with NAFLD don't have NASH. About maybe 15 to 20% of patients with NAFLD have NASH. And these are the patients that can progress to cirrhosis liver failure, and liver death or liver transplantation. You should also remember that patients with NASH and NAFLD have another peculiarity, which has to do with development of HCC. Now, obviously, patients with NASH who have advanced fibrosis, cirrhosis specifically, they can develop HCC. But in the context of NAFLD, even in the absence of cirrhosis, non-cirrhotic HCC does occur in the context of NAFLD. The rates are, of course, lower than those that are related to cirrhotic NASH. So screening for HCC in this context only apply to those patients who have advanced fibrosis and cirrhosis. Now, when you look at the population at risk, and of course, from being overweight and obese to having visceral obesity and other component of metabolic syndrome, such as dyslipidemia, hypertension, the most important risk is actually type 2 diabetes. In fact, when you look at this slide on the right, which is showing you the prevalence of advanced liver fibrosis, presence of type 2 diabetes is an independent predictor of advanced fibrosis. In fact, also an independent predictor of mortality in patients with non-alcoholic fatty liver disease. Another important issue is that when you have more and more components of metabolic syndrome, the risk of fibrosis increases, as well as the risk of liver-related mortality. So when you look at the issue of type 2 diabetes and metabolic syndrome from a perspective of a cardiologist, of course, you focus on cardiovascular events and cardiovascular mortality. And it's important to remember that even in NAFLD, cardiovascular mortality is the main cause of death in these patients. However, both our colleagues in endocrinology and also cardiology, as well as primary care physicians, have really ignored the other important perspective about the complication of type 2 diabetes and metabolic syndrome. And here we have the hepatologist view of the world, which is the fact that steatosis steatohepatitis can actually lead to end-stage liver disease, hepatocellular carcinoma, and a large number of deaths in this context. So I think a balanced view of this would be similar to what we advocate for patients with type 2 diabetes in terms of kidney disease, where primary care physicians have no problem ordering actually assessment of kidney function, as well as the eye complications of these patients, sending them to ophthalmologists. So I hope that as we go through the next hour or so about the data, that you see that our primary care physician colleagues and our endocrinologists and cardiologists understand that aspect of the complication of type 2 diabetes, and in the future would consider screening patients with type 2 diabetes for non-alcoholic fatty liver disease, especially those that are high risk non-alcoholic fatty liver disease. And of course, here we are also dealing with an important conundrum, which has to do with the fact that the prevalence is high, the disease burden is very, very high and increasing, but the awareness is quite low. Let me ask Mazen and Rohit to chime in and tell me about these, their perspective about low awareness and what we can do to help providers, increase the understanding of NAFLD and also how to really insist on the fact that patients who are seen by a primary care physician with type 2 diabetes or in the endocrinology sort of practices, that they should be screened. Let's just actually turn to Mazen first, and then we'll get perspective from Rohit. Mazen, what do you think?
I'm on mute. Thank you, Zobair. So this has been a problem, as you know, for the last few years. And if you go to a primary care or sometimes even endocrine, he will tell you, okay, if I find these patients, so what are you gonna do next? And you showed data, a lot of it came from you, and on the prevalence of the disease worldwide and how prevalent it is in diabetic patients and how prevalent the advanced fibrosis in type 2 diabetics. So a work like this has advanced our knowledge. You presented today late-breaking abstract on the billions of dollars with the B that is going to cost our health system to take care of these patients. So these data and the awareness should be increased and implemented in our system. But also, I think a lot of lack of awareness because we don't have drugs yet in the market. Later on, we'll talk about the drugs that they are coming. So hopefully that will increase awareness. Also, we have seen actions through ACG or AGA, through new papers that started calling for screening. We have done cost-effective analysis showing that cost effectiveness is already true. So I think with a lot of actions like this, we'll see more and more awareness. We started seeing it already on the endocrine, and hopefully the PCPs will follow after that.
Thanks, Mazen. That absolutely, you're correct. I think this is going to happen more and more. Hopefully, with the help of societies like the ACE Society from endocrinology and other non-liver and GI societies that will get involved. Rohit, what do you think about the issue of awareness and its importance?
I completely agree with you, Zobair and Mazen. The disease awareness is critically low. And I think the efforts that we are doing and AASLD is doing to develop the AASLD NASH task force, and then collaborating with other societies, and I know you've been involved, as well as Ken Kusi and others on endocrine side, working with the cardiology societies and diabetes and international societies coming together to develop a joint front would be important. Another feature, I think, is how to diagnose this disease non-invasively. And we'll look at that later in the session. If we are able to diagnose the disease non-invasively, then I think potentially it's easier, and also take the patient directly to treatment and then monitoring treatment response without needing invasive liver biopsy. And all those aspects, I think, would potentially lead to increased awareness because a patient's journey could be facilitated.
Absolutely, absolutely. I completely agree. Let me just share a couple of slides with all of you, and then I'd like to ask both of you a specific question. So when you look at patient level, and this is actually data from NHANES that we looked at, patients who have non-alcoholic fatty liver disease, only about 4.5% of them actually knew that they had any kind of liver disease. So in contrast, when you look at patients who had viral hepatitis from the same data set, about 38% of them actually knew that they had liver disease. So quite a bit of discrepancy here in terms of being aware of liver disease when you have it. So at patient level, the awareness is actually quite low. Now, when you look at the health system level, this is a study from a VA facility that was published a few years ago. And this is a retrospective chart review. And looking at the chart review, the investigators actually found that those patients who could have diagnosis of NAFLD, only 22% of them had the actual diagnosis. So you could look at the data and you look at the record and say this patient has NAFLD, but only about a quarter of those patients actually have the actual diagnosis of NAFLD. And about 15% of them received a lifestyle modification, and only 3% of those that could possibly have advanced fibrosis were actually referred to a specialist, a gastroenterologist or a hepatologist. So at the health system level, it's quite low. And finally, when you look at provider level, this is a global survey that we just completed recently. It's now published. And this is over 2,200 clinicians across 20 different countries from different part of the globe, but 40 countries actually from different part of the globe. You can see that when you look at endocrinologists and PCPs. PCPs have the lowest sort of some basic knowledge about NAFLD, followed by endocrinologists and gastroenterologists and hepatologists. So the provider level, there's actually quite a bit of challenge. Rohit, if you want to do one thing, to raise awareness, what would that be? And I'm going to come back to you, Mazen, with the same question. But let's say what Rohit is, sort of magic one thing that
yeah, I think if I could do one thing, then I would say change the screening paradigm among diabetics and put that as a quality of care metric, and I think that would be probably one thing that I would go for right now.
Fantastic. Yeah, I agree with you. I think that is probably where the gold is. And I think all patients with different components of metabolic syndrome, even if they're pre-diabetic and non-diabetic, probably should get screened. But to get started, I think the type 2 diabetics are where we need to go. Mazen, what do you think? If there is one thing you could do, what is it? What would that be to help in this area?
I mean, Zobair, that means I have to come up with something different now.
Yes, you do.
So, well, I mean, this is what we did in the gastro paper we published last year. We said, let's start with the diabetics and screen for NASH and F2 and higher. But I want to add to that, so I can come up with something else, go to their guidelines. I think guidelines is really, really important. And we see now the action happening on the ADA and their clinical society on the endocrinologist. I'm hearing some action happening in the primary care societies, but we really have to know what is their societies, what can change their guidelines, the task force, whatever it is, and implement it in their guidelines. So it is there, they cannot deviate from it, and we can go there for the type 2 diabetics and make it a must to do.
Absolutely, I agree. Guidelines are very important. Actually, interestingly, Mazen, in that survey that we just published, when you look at endocrinologists, gastroenterologists, and hepatologists, they actually look more at guideline. PCPs actually look more at sort of internet for their information. In fact, also CME programs like the one that we're actually looking, it was also a very popular sort of option for increasing awareness. And I think these two areas to focus on type 2 diabetes as potentially the cohort that would be at the highest risk for advanced fibrosis and NASH, and then really increase awareness through all these mechanisms, especially through guidelines, would be important. Mazen, I know that you have some very exciting data to share with us regarding treatment. Let's actually get started and talk about treatment first, and then we'll come back to Rohit to talk about how to use non-invasive tests to risk stratify patients in terms of candidacy for treatment. Go ahead, Mazen, please.
Sure. And since we talked about part of the awareness and just to show some of the drugs, we have some exciting drugs. So I'm hoping that the attendees will walk out today knowing what's in the pipeline, what's exciting out there, because we have some exciting news. We cannot talk about all treatments. That's going to take 2 hours, but we're going to at least talk about the phase 3 and what's happening there. But before we do that, let's talk about the objective. So we're going to review some of the existing recommendation, what's in there already out there. Weight loss and exercise is the backbone of any therapies, so we have to do it, and we build on top of that. So let's start with a case actually. This is Owen. So he's a 61-year-old attorney. He does have type 2 diabetes. He does have dyslipidemia and hypertension. He has central obesity with a BMI of 32. He eats high carb diet, and he drinks 5 to 7 alcoholic drinks per week. So that's okay per our guidelines. And he complains of abdominal discomfort with the right upper quadrant pain. A lot of our NAFL patients will come with that. They don't even notice it. And he currently takes metformin for type 2 diabetes and blood pressure medications. Let's take a look at Owen's labs. So his ALT is 60, his AST is 65, his total bilirubin is 0.8, albumin is 4, platelet is 180, his LDL is 130, HDL is 36, triglycerides is 235, his diabetes is not quite controlled, but it's not too bad, 7.1. And again, look at the pattern of liver enzymes and the platelets. So next slide. So let's take a question from the attendees. So Owen is diagnosed with NASH and is concerned about further weight gain. His BMI is 32. Again, is concerned about weight gain. Which one of the following you would not recommend for him? Again, you would not recommend for him. And look at his concerns and what he was diagnosed with. Exercise, optimize his metformin dose, pioglitazone, vitamin E, and I'm not sure. And I'll give you a second. Oh, let's see. So, okay. So I feel like, yeah, we had a tricky question like the boards. They have to trick you so you triple in the exam. So this guy was diagnosed with NASH. So what we try to do here is to direct you to side effects of the drug. So in the guidelines, NASH with type 2 diabetes is treatment, but Mr. Owen, the attorney, he doesn't want to gain weight. And he's telling you, I don't want to gain weight. So side effect of pioglitazone is a weight gain. So he's basically refusing pioglitazone, and pioglitazone is the drug that you don't want to give because it causes weight gain. So pioglitazone is the right answer because he does not want it. So kind of tricky question you get in the GI board. So let's move on for the next slide. So let's review the current treatments for NASH. Currently, there's no FDA-approved treatment. As you all know, weight loss and exercise, again, it's the backbone of all therapies. We should talk about healthy diet. We should talk about weight loss and exercise. We always emphasize on it. And we will talk about the pyramid in a second, but 3 to 5% is the principle of losing fat. 7% will lead to losing inflammation, and 10% is the way to lose fibrosis. I try to tell them you should go as close as you can to your ideal BMI. Diet, we can talk about it forever. Mediterranean diet has the most evidence in non-alcoholic fatty liver disease and NASH. They are more updated diet, more sexy. The fasting diet, the low carb diet, they have evidence here and there. So a lot of people are doing combination now. I do say that tailor it to the patients. Not all patients are the same. If whatever work on patient 1 does not work on patient 2, work with a dietitian if you can, if your center sponsor that or have way to reimburse your dietitian. The next slide will show you the pyramid and how this is well known to everyone by now. 5% will lead to steatosis improvement. The 7 to 10%, between 7 to 10%, you have improvement in the histology, the inflammation and ballooning, and the 10% will lead to improvement in fibrosis. The problem is not everyone achieves that, and failure in losing weight has been documented in the literature. So we all need further training on that, but also we need to support our patient in losing weight and exercise. So a quick snapshot of the AASLD guidelines, or what we have in our guidance. And of note, the AASLD guidance is being updated right now. So you will see more in the next few months, maybe next year. So lifestyle modification, weight loss and exercise. Currently, GLP-1s, SGLT2s, and bariatric surgeries are not recommended by the AASLD. If you want to recommend bariatric surgery on your NASH patients, usually you recommend it for weight loss and exercise. I want to direct you to a paper that was just published in JAMA this week, I think, that showed bariatric surgery is very helpful for liver outcomes. From Cleveland Clinic that my friend Dr. Alkori was on it. Vitamin E is recommended. There are 2 medications recommended for our NASH patients. One is vitamin E, the recommendation and the guidelines for biopsy-proven NASH in non-diabetic patients. It's not recommended for cirrhotics, although there's one study from Dr. Chalasani group showing benefit in cirrhotics. That study needs to be replicated. Again, it's not recommended in cirrhotics in the guidelines. Pioglitazone, it's recommended in type 2 and non-type 2 diabetics in biopsy-proven NASH, not in cirrhotics. These studies were done by Ken Kusi and published in Annals of Internal Medicine. Metformin has not shown benefit in patients with NASH in histology. Statins don't treat NASH, but they can be beneficial in medicating any dyslipidemia. And as you know, our patients die from cardiovascular disease. So if they are recommended for dyslipidemia management, go for it. As you know, as a hepatologist, we get a lot of consults for elevated liver enzymes, and they take them, first thing they take them off is statin. Orso is not recommended for NASH patients. Studies showed no benefit, neither omega-3 fatty acid. And we'll talk about obeticholic acid and GLP-1 in a second. So now let me show you some new therapies and closer look, but let's take a question first about new therapies. So the question says, which of the following agents in development can improve glycemic control, so glycemic control, and promote weight loss in addition to its potential histological benefit? So we don't trick you, let's refocus. Improve glycemic control, weight loss, and histology. So we're looking for three things. Aramcol, elafibranol, FXR agonists, GLP-1 receptor agonists, and I'm not sure. And I'm not sure is not a good answer in the exam. Yes, that is the correct answer, 80. Oh, I'm not sure, 8%. Good. So GLP-1s, from the type 2 diabetes data, they do promote weight loss. They do lead to glycemic control. And there are new exciting data that they show histological improvement. They're not FDA approved for that. There are new histology. There are new histology data that I will show you in a second. But let's try to see those. All right, so let's take a look. This is the roadmap for treatments. As you see, it's complicated. You see the box here on the left that focus on de novo lipogenesis and lipotoxicity. A lot of drugs target that for now. And then there are drugs that they target inflammation and then fibrosis, and there are drugs that they target the systemic process such as GLP-1s, and they focus on the weight loss. So we will talk about some of these drugs, especially that they are now on phase 3. So the first drug that we're going to talk about is the obeticholic acid. You heard us talking about it in previous presentations. Dr. Younossi, who's with us today, presented these data, and that was published in The Lancet. So obeticholic acid was the first drug to meet its primary endpoint in phase 3 study. And as you know, the primary endpoints is one of two things: either NASH resolution without fibrosis improvement. NASH resolution, you need to basically wipe out NASH. You're left with so little, or you get fibrosis improvement by one stage. And here, simply on the left side, here what they did, they achieved fibrosis improvement in the higher dose 25 milligram in 23% of the patient compared to placebo. On the right, they did not achieve NASH resolution. They did not need to do that. They just needed one of these points, and they hit that, and thus they were expecting FDA approval. However, the FDA required more data, maybe because of safety signal. So the company is trying to file for more data in the next few months. We'll see if the drug get approval or not. Next slide. So this is more analysis per intention to treat, and per intention to treat, they achieved fibrosis improvement as well as NASH resolution. But the previous slide is what the FDA is looking for. Again, they're trying to get more data to convince the FDA that this drug should move forward. Hopefully it will. It will be helpful to the NASH field. This is all news. Let's show you some more updated news. So this is resmetirom. This is the Lancet study in 2019 presented by Stephen Harrison. Resmetirom is expected to probably be the first drug that is going to be approved, but we'll see their phase 3 studies. This is their phase 2 study that was powered to meet the primary efficacy endpoint, which was MRI-PDFF reduction. Again, MRI-PDFF reduction, and here it's showing it to you nicely. On the left, relative reduction, on the right, absolute reduction. MRI is reduced nicely. Next slide. And here they also had biopsy as a secondary endpoint, and that's why we expect they probably hit their approval endpoints in phase 3 because they met histology endpoints in their phase 2, even though it was secondary analysis. So they hit 2 points NASH reduction. They did hit NASH resolution, and that's enough to meet phase 3 approval. Still, like, you never know what happens in phase 3. Fibrosis was not met, but again, it was not powered to do so. In their subsequent studies, they have been meeting a lot of fibrosis secondary endpoints, especially non-invasive testing. So for example, this is a study that they presented in EASL as a oral presentation. So this is one of their studies that is not a biopsy study. This is a study that designed as placebo, 100 milligram, 80 milligram, and look at this open arm 100 milligram. So they presented this data of 100 milligram open arm of 58 weeks and included MRI-PDFF, which measure fats, MR elastography, which measure fibrosis and liver enzymes. And I will show you the data in a second, but there was decrease in MRI-PDFF and MR elastography, as well as ALT and AST. There was also increase in other biomarkers, increase in adiponectin, which is a useful biomarker, decrease in ProC3, which is a fibrosis biomarker, again, decrease in fibrosis biomarker, and ALT and AST. Next slide. Here, this is the same one study, again, the 100 milligram. Here on the top, it shows you the decline in liver enzymes over the study period. The important one is the one on the left, on the bottom. So MRI-PDFF decreased by 53%. The liver volume decreased in the middle. The CAP score decreased by 53%. I cannot see it very well. The MRE, the absolute value by 0.4, which is good for MRE. The CAP decreased, the VCTE KPA decreased by 2. The percentage decreased by 10% MRE. It's very good. We have not seen that before in other studies. The CTE decreased by 20%, and lipid panels decreased as has been seen before with resmetirom. Those are good results for a drug despite not having a biopsy. So a lot of encouraging things for them going their way, and we'll see their histology data that's called MASTRO-NASH that is going to read next year. Next slide. Belapectin is a drug that actually targeting the cirrhotic group, and this is now in phase 2b/3 adaptive design. And this is a study that we were part of, and that was their phase 2. And in this study, there were 2 milligram, 8 milligram placebo. And the primary endpoint was change in portal pressures, the gradient. The problem was that they did not meet the primary endpoint, which was change in the hepatic venous portal pressure gradient. Again, they did not meet changing the gradient. But this is the caveat. When they did the sub-analysis in a group that they did not have varices, in the 2 milligram, again, they did not have varices, they did meet the primary endpoint. So the gradient changed. And also, this group did not develop varices. So now they are in the subsequent study, they're looking, their primary endpoint now, they're giving them the 2 milligram, and their goal is that these patients at baseline, they don't have varices and they will not develop varices. it's a good endpoint because your cirrhotic patient, if they don't develop varices and the placebo does, that means their portal hypertension developing while the drug is preventing that. A very important endpoint. So that's what the drug is trying to do now. It's an infusion drug, and the study is ongoing. Aramcol, the study was just published in Nature Medicine, and this is actually the secondary endpoint I'm starting with. So here, the study was powered to look for MR spectroscopy. Aramcol is SCD1 inhibitor, which inhibit de novo lipogenesis. And this is secondary endpoint looking for histology. Those are looking for proportion for patient here, looking for NASH resolution. They did have, it looks numerically higher in the 600 milligram, but that was not statistically significant. And the fibrosis improvement, it looks higher, but it was not statistically significant. On the next slide, you will see also, this is the primary endpoint here on which was MR spectroscopy changes, and that was not statistically significant, unfortunately, here on the second line, which was this change by minus 3.18. However, when they did sub-analyses, there was subgroup that was statistically significant, and thus they are continuing in the study in their phase 3. So in sub-analyses, some patients were statistically significant. They had changes in ALT and AST, so they are moving along with the drug, and we'll see where they go. There was signal in the histology that it might be statistically significant, although the placebo was quite low compared to other studies. Looking at semaglutide, this is the hot news that came out this year. They actually had 2 New England journals on semaglutide, one on weight loss that I will point you toward, and you can go and read it there. The other one is semaglutide and NASH. And they already have the semaglutide approved for weight loss based on the other New England Journal study. So this study, the GLP-1, semaglutide is a GLP-1, has been used for diabetes for some time now. Phil Newsom is the first author, and it's already approved for type 2 diabetes. And let me show you the design of the study. Actually, this is the primary endpoint. They looked for NASH resolution versus fibrosis improvement, and they achieved NASH resolution in up to 59% of the patient. This is one of the highest NASH resolution we have ever seen compared to the placebo, only 17%. Again, this is the highest NASH resolution we have ever seen. Next slide. They did not meet fibrosis improvement in F2 and F3 patient, but they got really unlucky that the placebo was up to 33%, one of the highest fibrosis improvement that we have seen in the placebo. So in their F2, F3, they achieved it at 43%, but the placebo was quite high. So they achieved NASH resolution. If they do that in their phase 3, it will give them FDA approval. A lot of patients lose weight, up to 18, 19% in this study, which is what the drug is supposed to do. Next slide, please. So this is the body weight. I'm sorry, up to 12, 13%. The 18, 19% was in their weight loss trial. And the hemoglobin A1C dropped nicely. ALT and AST dropped, they dropped nicely. So as the lipid panel improved nicely. Next slide. So this is the lipid panel changes, which is very important in a disease that has cardiovascular comorbidity. The semaglutide already has data in type 2 diabetes patients that they improve cardiovascular outcomes. So it's expected to do that in NASH as well. Next slide. Side effects, it's known that semaglutide, one of its, or GLP-1s in general, they do slow the gastric emptying. So nausea is one of the big side effects. It's expected that more patients semaglutide had nausea and GI side effects compared to the placebo. There were 3 doses in this trial, 0.1, 0.2 milligram, and 0.4 milligram, and they titrated them up, especially in the 0.4 milligram. And when you titrate it up, it's more tolerable than if you just start them on 0.4 milligram. And that's what they do with the weight loss drug right now. So it's expected to be done if the drug gets approved. Another also hot off the oven, or fresh off the oven, if you want to say, another New England Journal trial. So it's good to have two of them in the same year, very encouraging for the NASH field. This drug is lanifibranor. I'm going to call it Lani. And Lani is pan-PPR agonist. And you know how the PPR are beneficial in terms of lipid and glucose metabolism. This is a randomized control trial that had 6 months duration, shorter than the semaglutide trial. And let's look at the primary and secondary endpoints. This drug actually did hit all endpoints, primary and secondary endpoints. They had NASH resolution, they had fibrosis improvement, and they had met both NASH resolution and fibrosis improvement together. So a very promising drug that is now in phase 3. Next slide. I'm going to finish my talk with the concept of combination medications. We believe that the field of type 2 of NASH is going to be like type 2 diabetes. You start your patient on metformin, and a lot of patients end up on metformin, SGL2, and something else. We believe that NASH is going to be the same thing. And this is an example of collaboration between Gilead and Novo with two Gilead drugs, which is Cilofexor, which is FXR, Frescostat, which is ACC inhibitor that submit de novo lipogenesis, and semaglutide with a GLP-1. So next slide. Here it's an open label study that combines Sema and Fresco, Sema and Silo, and you have all three drugs together. So let me show you here. I want you to show you the table down here and look at the three drugs here. You see this 92%. When you combine all three drugs, you achieve more than 92% of patients achieved more than 30% reduction. That's a huge reduction that the patient achieved. Next slide. Also, when you have the three drugs together, they achieved more reduction on liver stiffness on FibroScan and more than 25% reduction FibroScan. So it's a proof of concept study that the combination therapy is doing. Now they are in a histology study that just started, and we'll see what this triple therapy do. I think they combine the Frescostat as well as the Cilofexor in one pill. So we'll see what their future study look like. So Zobair, this is like I think the fresh off the oven medications that we have and the New England Journal studies, and that's what in the pipeline for the phase 3. I will hand it to you to talk about the next steps that you have in mind.
Thank you, Mazen. This was fantastic. It was just really, truly an excellent review of what we currently have and what we have potentially coming in the future. Now maybe we can ask the audience to ask any questions. But meanwhile, let me just actually throw this at you. I mean, there are two approvable sort of endpoints that the FDA and EMA are pushing out there. One is the resolution of NASH, and the other one is the improvement of fibrosis. Now, which one of those two you think is probably more important in terms of outcome from your perspective?
So there are data. I mean, now I know which one you want me to say, Zobair. I know your opinion. So, we're talking about New England Journal's papers today. It's just show you how the field is moving fastly and the great results we're having. There was another New England Journal paper in the last 2 months also. The NASH CRN and Arun Sanyal just published a paper on the importance of fibrosis. Nothing new, but this is also prospective study that done from the NASH CRN. Rohit is part of it as well, showing you that fibrosis matters. and it's the most important prognostic factor in this disease. And if you improve fibrosis, the disease will improve. There was also a paper in Hepatology also published that if you improve fibrosis, you improve outcome. So this is very important for the disease. I will go by that. But also, we have to keep in mind it's also a systemic disease. You need to look at the patient as overall. Patients are overweight. There's cardiovascular mortality. So, for instance, we talked about GLP-1. So, if patients lose weight, their cardiovascular mortality is better. You showed data earlier today that cardiovascular mortality is very important. If they improve that, is very important as well. With the SEMA data, I want to point out there was less progression to cirrhosis in their supplementary data. So hopefully they will mitigate the placebo effect in their phase 3, and they will show improvement in fibrosis in their phase 3.
Great, thanks, Mazen. Rohit, I want to sort of ask you something a little bit different. Is that if you look at sort of your perspective over the next, 2 to 5 years, what drug or what maybe combination of drugs do you think will come up to at least clinical practice next from your perspective?
Yeah, I think this is really important as we see. I think we've got some exciting phase 3 programs that are on their way. One is on semaglutide versus placebo in patients with stage 2 or stage 3 fibrosis. I think readout of that, Madrigal's thyroid hormone beta receptor agonist, resmetirom, that program readout, I think, is also coming along. And I'm really hopeful and rooting for, both of these programs to be successful because it really provides different types of drugs to our patients. And once we start seeing 1 or 2 drugs getting approved, I think this will really enrich the field and bringing others to take more risks in terms of working on cirrhosis in patients with NASH. But I'm absolutely confident that we will have a drug for treatment of NASH and NASH-related fibrosis in the next few years.
Fantastic. Thanks, Rohit. I agree. I think with both of you. I guess I've been always biased that fibrosis is really important endpoint. They're collinear in my view. I think NASH, is so collinear with fibrosis that in general you would see if you have improvement of steatohepatitis, you would see some fibrosis improvement. At least that's my bias. Although some of the studies there's discrepancy in the semaglutide and also in obeticholic acid, but I'm sure. Ultimately, when we have really highly efficacious drugs, that we'll have both of them. But now maybe you can just move to Rohit, and we saw some great, wonderful data from Mazen about new treatment, and we saw the burden of disease that I shared with you. So there is, of course, a number of options. Hopefully, that will be on the horizon, and we'll go to you, Rohit, and talk about this patient Owen. And see how you can actually use non-invasive tests. And this would be the third, of course, learning objective, that we have to select the appropriate diagnostic to risk stratify patients. This is about not only just not screening with non-invasive tests, but then how to take the patients that have fatty liver disease, have some degree of fibrosis, and then find those patients that have the highest risk to develop adverse outcomes. So over to you, Rohit. Maybe you can now review some of the non-invasive tests for us. You're on mute, Rohit.
Thank you so much, Zobair, and thank you to Mazen for setting the stage for me to take on from here. Let's review, revisit Owen's history. Owen is a 61-year-old attorney. He's got type 2 diabetes, dyslipidemia, hypertension, central adiposity, BMI of 32.7 kg per meter square, a high carb diet, and 5 to 7 alcoholic drinks per week, has mild right upper quadrant discomfort, takes metformin for type 2 diabetes, is on ARB for hypertension. Looking at the labs for Owen, ALT of 60, AST of 65, total bilirubin 0.8, albumin still normal at 4, grams per deciliter, platelet count 180,000, LDL cholesterol 130, HDL is low at 36, triglyceride elevated at 235, hemoglobin A1C at 7.1. So here's a question for you, and I would like to see what you would, how you would risk stratify this patient. You and Owen agree to screen him for high-risk NAFLD. Which of the following is the next step for risk stratification? A, liver biopsy. B, FIB4. C, MR elastography. D, transient elastography or fibroscan. E, I'm not sure. Excellent. I think so. We see 22% said FIB4 and 51% went to transient elastography. I think it's both seem to be correct, but we asked the next step for risk stratification, and so that's why I think the correct answer here is FIB4 with that caveat. But we'll discuss, and I agree. We probably do a sequential assessment, and after the FIB4, probably get a transient elastography in the setting of the clinic. Now, moving on to non-invasive tests that are available for NAFLD assessment and risk stratification. To the left, I'm showing you some of the clinical prediction rules, as well as some biomarker panels that are available. Those that are in red are that are commonly used or potentially utilized currently and may be utilized. And to the right, I'm showing you imaging-based modalities, and the ones that are commonly used are top two in clinical practice: transient elastography and MR elastography. ELF, fibroscan, AST score. Mazen really talked about this earlier on treatment response. We're going to discuss a little bit more, and then moving on to FIB4 and FibroSpect as well. Now here we see in terms of, I would say, the first line of defense or first line of attack on non-invasive tests is FIB4. Some people do use NAFLD fibrosis score, so in the lieu of completion, I've put it there. But typically what I'm using, and I spoke with Mazen and Zobair as well, in their clinics also, we typically utilize FIB4. It includes age, ALT, AST, and platelets, and it is helpful in ruling out advanced disease. So a score below 1.3 is associated with low likelihood of having advanced fibrosis, which is stage 3 or stage 4 fibrosis. Now, patients who have a FIB4 that is 2.67 or higher have more advanced disease, and they have reasonable likelihood of having stage 3 and stage 4 fibrosis. Now, positive predictive value of FIB4 is not high, but the negative predictive value of FIB4 is really outstanding, and that's why we use this test. Now, if you are between 1.3 and 2.67, you might need additional testing. And I think many of you are astute clinicians. You probably already guessed it, that this patient probably will be intermediate, and that's why you probably picked FibroScan as one of your answers. Now, moving on to other tests that are now recently becoming available is Enhanced Liver Fibrosis Panel. Here I'm showing you, this is a panel that consists of 3 metabolites: hyaluronic acid, P3NP, and TIMP1. You could utilize it to find the stage of fibrosis for a particular patient. And this is common across all liver diseases, but a test that gives you a reading of 9.8 or higher is associated with stage 3 fibrosis or higher, and 11.3 or higher is associated with cirrhosis. Now, what about some of the imaging-based modalities that are available to us in clinic? Those include here, I'm showing you example of 4 of those for liver stiffness assessment. One is FibroScan or VCTE, shear wave elastography, RFE, or MR elastography. All of these modalities provide liver stiffness, but use slightly different physics equations to derive those, and also use different platforms, with FibroScan, shear wave elastography, and RFE using ultrasound as platform, and MR elastography using MRI as platform. Here I'm showing you some data on the FibroScan and long-term outcomes associated with liver stiffness at baseline among patients with biopsy-proven NAFLD. You can see that as the liver stiffness increases, the risk of liver-related outcomes increase. And so this is really important, that baseline liver stiffness is prognostic in nature. Higher the liver stiffness, higher the risk of liver-related mortality and morbidity. And I'm going to show you some specific data that is new later on in the presentation. In terms of comparative accuracy and accessibility of non-invasive tests, I would say the most accurate test for detection of fibrosis or advanced fibrosis is MR elastography. Of course, you would require an MR unit for that. Therefore, easiest test to utilize or available as a next step, we said, would be a FIB4, followed by a FibroScan or ultrasound-based modalities that are easily accessible. Now, you can also imagine a scenario where there's no liver clinic, but you could do a blood test. So potentially you could send out blood test for assessment of ELF and could risk stratify after a FIB4 assessment. And that might also be relevant. And this has been done in parts of the UK health system where they used, instead of a FibroScan, ELF test as the second test to risk stratify patients with NAFLD. Now we're going to take a look at a question, and I would like to see your response. Owen's FIB4 score is 2.2, and I think you already guessed it, which puts him in the intermediate zone. What would be the most efficient next step to risk stratify Owen? A, attempt lifestyle modification in non-elastographic NIT to potentially narrow the indeterminate zone. C, rule out or in advanced fibrosis with transient elastography or MR elastography. D, liver biopsy now. E, B or C, F, I'm not sure. Excellent. So here we are seeing that many of you picked transient elastography again, or MR elastography based upon your practice, but 47% of you picked B or C, where you could use either transient elastography or MR elastography, or you could use ELF that I showed you, or FibroSpec. So there are tests that are available that could also be utilized and could help you risk stratify your patients with NAFLD. And the reason we didn't pick liver biopsy was we were asking what would be the most efficient next step to risk stratify Owen here. Now moving on to optimizing risk management. Here you can imagine that maybe about 80 to 100 million Americans have suspected NAFLD or NAFLD. We want to rule out advanced fibrosis, so let's apply FIB4 first. FIB4 below 1.3, we think these individuals are low risk. Now these patients could potentially be monitored, and then you could potentially repeat their FIB4 every 1 to 3 years and see if their FIB4 increases. And if it increases, then you can see if they would be in a different category. If the FIB4 is greater than 2.67, then those are high risk. Those patients may directly be seen in the liver clinic, or you might still consider doing an elastography assessment or a ELF assessment. Those that are intermediate risk, that is a FIB4 between 1.3 and 2.67, those definitely require a second line assessment. And I think Dr. Noureddin previously alluded to the fact that these pathways are now consistent with other guidelines, whether they're AGA, ASLD, EASL, and we have new ASLD guidelines coming up in the next few months, which will also be reflective of how you can really follow a patient's journey through an algorithm. And we're going to try to make things easier for clinicians. Moving on to once the patient has been established and referred to you for NAFLD assessment, I think there are key features that we want to still assess clinically. Does the patient have ascites, congestive heart failure, severely high ALT? Now, ALT is 300. That's probably not driven by fatty liver alone. There might be something else going on. Risk factors for other liver disease, rarely we will see autoimmune hepatitis mixed in there. And if those factors are present, this patient needs clinical workup irrespective of what their elastography is. It's really important. Suddenly a patient's ALT is 700, and that patient is not appropriate for a FibroScan assessment. You really want to think about why did the ALT go from 50 to 100 to 700, what's going on? And just because the FibroScan is 6 doesn't mean that patient doesn't have a liver problem. I think this is critical, and this is really important as we work with our APP colleagues and our trainees to tell them how and when to utilize these tests for risk stratification. Now, at our unit and some of the centers, the BMI is 35 or higher. Some of the ultrasound-based modalities do not work as well. So we might choose directly MR elastography. If MR elastography is below 2.55 kilopascal, you probably don't need a biopsy. This patient does not have high risk for having fibrotic disease. If the FibroScan is below 6, again, no liver biopsy is needed. Now we've actually taken up and brought it a slightly higher, 8 kilopascal. And so people who are above 12 kilopascal, we think they probably have stage 3, potentially high risk for fibrosis. But again, FibroScan has low positive predictive value and low specificity compared to MR elastography. And therefore, I think understanding a patient with a body mass index of 40 kg per meter square can actually have a FibroScan that may be 9, but they, when on biopsy, may not have any fibrosis. So I think just understanding that is important. And so you're not surprised, and you actually built up and you really told the patient that they are going to die from cirrhosis. And then when they come back, they're really surprised. That happens. You routinely see one consult a month, which is basically reconciling the FibroScan done elsewhere, and the reading was too high and patient thought that they were dying from liver disease. And so I think it's important to have that assessment done in terms of the results from a test. I'm going to show you this recent data based upon pooled data from 4 different trials that Zobair, and Mazen, and others have worked on. And in this particular study, what we did was we looked at, can we see a baseline liver stiffness value? And can that predict progression to cirrhosis? And we are able to identify that cut point here. And you can see it's about 16 kilopascal or so. And then once you are cirrhotic, among cirrhotics, what predicts decompensation? And you can see that this is a much higher liver stiffness value than you would have thought. So, 30 kilopascal or higher is when you're seeing in a NASH cirrhotic risk of liver-related events. So even within patients with advanced liver disease with liver stiffness on FibroScan ranging from 16 to 75, this can be helpful in risk stratification. We also wanted to know if you had higher liver stiffness, what are the odds of disease progression? This can be helpful in developing sample sizes for trial. We're working on liver cirrhosis network, and some of these data are being helpful for us to determine the outcome rate based upon the baseline liver stiffness that the patient comes in. We also want to look at if there's an increase, what increase in liver stiffness by how much is associated with a clinically meaningful increase in liver outcomes. We're thinking about 5 kilopascal in the setting of cirrhosis or bridging fibrosis, where it becomes clinically significant. So somewhere around 20 to 25% increase in liver stiffness on FibroScan is potentially clinically significant. Zobair and Mazen, I wanted to get your input on some of the new data. There's tremendous data on non-invasive biomarkers that is coming. Briefly you discussed, Mazen, on fast score. There's this new score, MAFib, that we came up with, and just wanted to have a discussion going here. So MAFib is a score which is a combination of FIB4 plus MR elastography, and we just try to make it easier for clinicians to use. So if your FIB4 was greater than 1.6 plus, so your indeterminate zone, so this is our patient, and their MR elastography was more than 3.3, then this patient has 90 to 97% positive predictive value of having NASH stage 2 fibrosis or higher. And then here we are showing Nobuharu Tomaki from our group, who's visiting from Japan, showed that MEFIB is superior than FAST score. So FAST, one problem with FAST was that is always accessible, it had a low positive predictive value. And we wanted to improve positive predictive value because if the test is positive, clinicians want to tell their patient that you have a particular disease. But if the positive predictive value is low, you may end up telling the patient that they have significant disease, but they actually may not. So understanding those limits would be important. Maz and then Zobair, what are your thoughts in these new scores? And Mazen, you worked on MASH score as well. So you want to briefly provide your thoughts on, MAFib and FAB and MASH and where things are going in risk stratification for inclusion into clinical trials?
Yeah, so are you getting an echo?
No, you're good.
Oh, okay, sorry. So we don't throw too many names. I'm getting an echo here. Hello? Okay, so we don't throw too many names. I think this is a fabulous score, Rohit. And the reason why is we really want to move beyond the biopsy. And where we at right now, we are, I want to use correct words. I don't want to say we're stuck with liver biopsy in phase 3. It is really, we have relied on liver biopsy for decades because it's a safe backup for us. We know what to expect from it. We know that improving fibrosis on biopsy translate into the outcomes. You led this concept about MRI and its changes and stiffness. So it's a new field that started showing correlation with histology and outcomes. And between serum biomarkers and stiffness, we are optimizing the imperfect standard, which is liver biopsy, to reach what biopsy can reach. So you started with MR elastography. You added a serum biomarker to improve positive predictive value. So what you guys showed with MR elastography, adding FIB4, you went just beyond the accuracy of detection to improve positive predictive value. And then nicely you showed, in addition to detecting NASH patients with F2, you're better than a FAST score. We're not trying to shoot down the FAST score. It's practical. It's an ultrasound machine. You can do it in the office. But for accuracy for clinical trials, with a test like MEFIB, like you have high positive predictive value, have higher accuracy. Also, to increase the confidence of the regulators that we are confident of what we're doing, I want to point out another presentation that was done by one of the thought leaders, Dr. Ajmera, earlier today from your group, that you showed accuracy, you increase the positive predictive value, then the next step you show correlation with outcome, which in an earlier presentation he did show that MEFIB also predicts outcomes. So that's what's the MEFIB score. The MASH score, we said is coming in Journal of Hepatology this next month. We basically said, okay, if FAST score works on FibroScan, we're just going to replace all the component of FAST with MRI components. The fat on MRI, elastography on FAST and on FAST score with stiffness on MRE, and AST with AST, and we did better than the FAST score. Again, we're not trying to say it's better. MRI is better overall, and it has its own use and its own setting. We need to show it correlates with outcome. Today in this meeting, we showed it actually predicts treatment response with resmetirom. It was oral earlier today. So we're just like all these efforts, we're moving beyond the biopsy because data like Zobair's data is showing it's very prevalent disease, millions of people that cost billions of dollars. We cannot just go around and biopsy everyone. And with efforts like this, I think we're going to move beyond the biopsy and convince the regulator that biopsy is not the way to go for phase 3. We biopsy a lot of patients in phase 3, and a lot of them go screening failures. So That's what I think of the newer data. It's a step forward toward moving away from liver biopsy.
Thank you, Mazen. Thank you, Zobair. Your thoughts?
Yeah, no, I actually was just, reiterate what both you and Mazen were saying, that it is really going to be a combination of different tests. I think the point that you made, that the negative predictive value of these tests, even alone, is quite high, the negative predictive value, so that you can exclude cirrhosis pretty comfortably. Of course, the issue is about positive predictive value of having advanced fibrosis, or actually high-risk fibrosis, which means stage 2 or higher. Now, you have, of course, MRE, FIB4 and MRE, and that you've shown that has a very good positive predictive value and potentially can even correlate with outcome. There's a paper that we just published about a month ago using FIB4 and ALF test that actually for cirrhotics, and in fact, another analysis shows that even very, very high positive predictive value for even those who are considered at high risk, meaning if 2 and higher, that would be can be attained by using FIB4 followed at a different cutoff at FIB4 that you showed, and a different cutoff of test that can be utilized for identifying patients who are at risk for advanced fibrosis, or who are potentially candidates for clinical trials. That means basically stage 2 or higher. Now, even today, with the late breaker, Rohit, you were there, Arun presented some data from NIMBLE consortium, which is from the United States. And also, I think at the last European meeting, we had presentation from Litmus, which is the European consortium for new biomarker. And there are a number of biomarkers that would be that even the existing ones that are of interest. What's actually interesting to me is that FIB4 by itself is a pretty good non-invasive test that costs nothing at this point, right? So it's a great test to use. But of course, when you get to sort of that gray zone, then adding something else, MRE or a FibroScan or an ALF test, would actually enhance that performance. And in fact, I think the NIMBLE study showed that, and I think they looked at everything from FIB4 to ALF to transient elastography to fibrometers and NES4, except I think NES4 was the only one that was associated with steatohepatitis, but or had good prediction of steatohepatitis, but ALF and I don't think they had MRE and transient elastography had pretty good performance in terms of fibrosis. But what do you think, Rohit, in terms of new tests, other tests that could use other technologies, lipidomics, proteomics, other things that can be much more, or even genomics that can risk stratify? We didn't talk about the genomic testing that could potentially also be an important predictor of who will be at risk for not only fibrosis but also development of HCC in the context of steatohepatitis. What do you think of the genomics and SNPs?
Yeah, I think that's really a good and emerging area. Genomic risk stratification for treatment is also there. Genomic risk stratification for future risk for developing cirrhosis. We recently came up with a genetic risk score for cirrhosis. I think others have also pulled in 5 different genotypes and showed that if you had PNPLA3, TN6SF2, MBOT7, GCKR, and protection with HSD17B13, then just these 5 could potentially explain the risk for future risk for HCC and decompensation. One of the other, in our genetic risk score, what we found was the number one, among all patients with cirrhosis, not just NAFLD, the number one gene that's responsible for cirrhosis risk is related to alpha-1 antitrypsin, SERPINA, followed by PNPLA3. But PNPLA3 might be more relevant because the number of people have it and how common NAFLD is. And then another gene that was previously not looked at, but now is more and more being looked at as a therapeutic target is MAC1. And that might also be related to cirrhosis. And of course, TM6SF2, GCKR, and MBOT7 are relevant in NASH and lipotoxicity.
Great. Thanks very much, Rohit. And thanks, Mazen, for both of your fantastic insights about treatment, NITs, and NASH in general. Now, before we get to our audience questions, let's wrap up by just reviewing our smart goals that you can carry into your clinical practice. So the first important goal of this symposium, and also for what you can take to practice, is that you really need to screen patients with type 2 diabetes for non-alcoholic steatohepatitis. The second, of course, is to counsel patients with cardiometabolic disease or risk factors, including the type 2 diabetes, about nutrition and exercise to reduce risk. Remember, this is a treatment that is currently available. It is, so we always talk about no treatment for NASH. This is actually a treatment, as Mazen showed, that lifestyle modification can be helpful. Now, of course, it's hard to achieve and hard to sustain, but it is going to be effective. Now, the third point that Rohit emphasized quite a bit is that you can use NITs, non-invasive tests, to risk stratify patients with potential NASH, and especially what we call high-risk NASH. And fourth is that you could actually look at these NITs, and especially the ones that are coming up, in terms of monitoring patients for progression of NASH and progression of liver disease. And in fact, data from the Mayo Clinic and data that Rohit alluded to shows that changes in stiffness can actually predict the outcome of patients with NASH, long-term outcomes. And finally, keep current with safety and efficacy of emerging therapies. There are a number of drugs that are coming down the pike, and you've heard that some of these are potentially available in 2022 or 2023. Also, please remember that there are extrahepatic benefits for some of these drugs. For example, weight loss, which is quite important for our patients, lipid profile, glycemic control, and most importantly, cardiovascular risk, the number one cause of death among patients with non-alcoholic steatohepatitis. So the drugs that have that beneficial profile, of course, would be highly beneficial to our patients. So now we can invite our audience for questions, and we've already received a number of these questions. So I'm going to go ahead and get started with some of the questions, and I'm going to ask the first question actually from you, Rohit, that in terms of cardiovascular risk, do you think semaglutide for patients with NASH is the drug of choice, or do you have any other combination that you can use semaglutide? And in that context, if semaglutide is being used for treatment of diabetes, it already probably is making some difference in terms of patients with NASH, because the prevalence of NASH is so high in the context of diabetes. What do you think about it?
Thank you, Zobair. This is really important. So first, I want to make the statement that semaglutide is currently being tested in a phase 3 trial in patients with NASH stage 2 or 3 fibrosis for assessment of its value and utility in patients with biopsy-proven NASH with fibrosis to see if it improves NASH activity in NASH fibrosis. But the question relates to cardiovascular disease improvements in a diabetic. I would say that there are many therapies that have been shown to improve cardiovascular risk. Of course, semaglutide and other GLP-1s are a big part of it. We see improvements in glycemic control. We also see improvements in weight loss, and weight loss itself may have positive effects and long-term data showing cardiovascular protection. But there are other drugs that are also in development in NASH therapeutic landscape that may also reduce cardiovascular risk. Potentially, they may have an effect on LDL reduction. They may have an effect on increasing HDL. And just to name a few, thyroid hormone beta receptor agonists reduce LDL cholesterol, FASN inhibitors potentially reduce LDL cholesterol, And then even FGF21s may actually improve adiponectin and have a positive effect on HDL. So there are a plethora of drugs that may have positive cardiovascular benefit, including PPAR alpha ligands that may reduce triglyceride levels. I do believe that GLP-1 analogs have an important role to play. I forgot to mention SGLT2 inhibitors. I think those also may improve cardiovascular risk. But again, the key thing will be which of these drugs will have efficacy in improving NASH and NASH-related fibrosis. And then we also want to reduce CVD risk in our patients. Thank you.
Thanks, Rohit. Mazen, this is a question about screening in the primary care setting. Since most of these patients come in not with a single risk, if they're obese, or they're diabetic, they're potentially also obese, and they probably also have hypertension, dyslipidemia. At what point do you think that the primary care physician should screen these patients? And specifically, if there is a liver enzyme test done, the year before, or 2-3 years in a row, and they're normal, or there's an ultrasound that doesn't show any evidence of fat, at least read by the radiologist, and the patient is still diabetic, would you still recommend screening or not, Mazen?
I can go on the data for an hour. So based on the cost-effective analysis we have done, I would recommend starting screening type 2 diabetics. We used your Markov model, Zobair. We went at age of 55, then we projected it to age of 40. So I would say start with FIB4 based on the AGA guidelines at age of 40. But your presentation earlier today made me think if we should start at the age of 45 based on the pockets you put. So start at between age 40 and 45. And I think we really should focus on the type 2 diabetics for now, not metabolic syndrome, not hypertension, not overweight. Let's just start with the type 2 diabetics, FIB4, between age 40 and 45. And let's repeat it every 1 to 2 years, FIB4. So message is easy and simple. And I think most of us are focusing on the same message in type 2 diabetics. The age is still questionable, but I would say personally, I will start with age between 40 and 45.
Thanks, Mazen. Rohit, there's a question about the new AASLD guideline or guidance. Do you expect significant changes in the new guidance document? I know you're in the writing group. I'm in the reviewing group of the guideline. But what do you think?
Yes, we are expecting and working really hard as a team of expert and working with the writing committee as well as reviewers. Then we expect major changes and really with the lens of a clinician. What can we do to make the life of a clinician easier, and those guidelines to be applicable? So you can print it and then actually treat your patient using those guidelines. That's the idea.
Fantastic. Thank you.
Thank you.
A lot of great questions, Zobair. A lot of questions. Thank you, guys.
Mazen, there is actually another question that I think you could answer. NAFLD can also drive diabetes development, and there is some evidence that this is sort of a bidirectional sort of relationship. We focus on type 2 diabetics. Now, do you think that patients with obesity, with a BMI of more than 30 or waist circumference, that make them obese should be screened? And I want you to just maybe also focus on the difference between total body weight as represented by BMI versus visceral obesity, and tell us which one is more important in the context of NASH.
So you're saying obese non-diabetic?
Yeah, so obese non-diabetic that potentially is probably insulin resistant and may not be clinically overtly diabetic, but shouldn't those patients be screened?
So I don't know the answer, Zobair, because the 2018 guidelines, they went all the way and they said, do not screen because we don't have cost effectiveness. When we did our cost effective analysis, we tried to tease out the obesity cost effectiveness data. We could not. maybe you have more data. We went after the diabetics because it was just a cleaner area to go after. We have data from the NHANES 2017, 2018 that fibrosis is absolutely higher in type 2 diabetics compared to just obese non-diabetics. So I would say I have confidence in screening diabetics compared to obese patients. It's possible and plausible that obese patients will be also cost-effective to screen. I would love to screen them, but I can answer with confidence that type 2 diabetics, based on data, are cost-effective to screen. It's likely that if it's up to me as a clinician, I'll screen them, but as a society, I think we need more data. I don't know what's your opinion on that.
Well, I think when you look at the long-term data, and we published something from NHANES, I think it was earlier this year, that when you look at sort of different body composition, and it is really the visceral adiposity, it's the waist circumference that drives mortality in patients who are quote unquote lean NAFLD. So if you've got normal BMI but you're obese, centrally, mortality is significantly higher. So I think we need to sort of at least consider, and this is also associated with the fact that it's really the waist circumference that is a better indicator of insulin resistance. That is the pre-diabetic sort of condition.
I hear you. You're the one who puts the $ data. I took it from you and I put cost-effective analysis. You just have to put the $ data and convince people to screen those people.
Yeah, no, I agree. I think that's what we need to do. Rohit, there is a question about, if you don't have MRE and patient really don't want to have a liver biopsy, what do you order as an alternative? Now, ELF test was just FDA approved, and by the end of the year will become commercially available. Do you do ELF testing? Do you do FAST? What do you recommend?
I think I would just go with plain and simple, FibroScan assessment would be good. If you get a good quality FibroScan, if the liver stiffness is below 8 and their FIB4 was also below 1.3, those patients currently could be managed without, major interventions in the liver clinic, and those could be given a yearly or every 2-year follow-up. I think that would be totally reasonable and not entertain a biopsy. They should still undergo lifestyle interventions, and that's what I will do. Those that are between 8 to 12, potentially 8 kilopascal, 12 kilopascal on FibroScan, maybe intermediate category, and then within those that are closer to or above 9, probably have fibrotic disease and should consider for a liver biopsy assessment. Those that are 12 or higher probably have advanced fibrosis and should be considered. Anyone who has a good FibroScan, I think they have a low platelet count and a FibroScan of 16 or higher, I am thinking that they may be cirrhotic or close to developing cirrhosis. And therefore, I start assessing for HCC screening and surveillance in that setting.
Let me help one of my mentors. So they had a tricky caveat that they don't want a liver biopsy. I want to add one point that also, if they really don't want a liver biopsy, there are a couple of things from the previous meetings. We still have to see it in our hands, which is the Agile 3 and Agile 4, which is by FibroScan. And I think it's in their app already by EchoSense. So it increases your confidence for F3 and F4. So after you get, as Rohit said, a FibroScan of 12 and FibroScan of 14, and it tells you cirrhosis or F3, I do agree with Rohit, maybe liver biopsy is the best thing to do. But if your patient is insisting not to do that, and you don't have access to MRE, which is very accurate, you can try these scores nowadays.
Yeah, I agree, Mazen. I think those could definitely be looked at. We are presenting data. I think Zobair is also on that abstract with Agile 3 for bridging fibrosis and Agile 4 for cirrhosis. Actually, it's not any better. The C statistic is not better than the FibroScan itself. So it's that's why I think you probably are better off just with the FibroScan score. But I think it's worth using it maybe in a different context. Might help. I agree.
Well, let me actually. There are a few questions that I'd like to just quickly answer, and then I'd like to ask both of you some important question that's out there in terms of endpoint. One question is oral semaglutide likely to be effective? Oral semaglutide has not been used for treatment of non-alcoholic steatohepatitis. It's for obesity. At the moment, I don't see at least a advanced phase for treatment of NASH. The other question is, what other tests would you do for elevated liver enzyme? Remember, NAFLD is a diagnosis of exclusion. You have to exclude viral hepatitis, you have to exclude autoimmune liver disease, and you have to exclude excessive alcohol use. So all of those things are important. And finally, there's a question about, as a hematologist, what NIT should I use if a patient comes in with thrombocytopenia? They said when you have thrombocytopenia and you think that the patient has hypersplenism and cirrhosis, you can certainly start with a FIB4, but I think the next test would be to go with, at least at the moment, since we don't have alt testing available, is to go with a elastography, either transient elastography or MRE. I think at least I would recommend. Now, Rohit, you could start with this. Do you think that the endpoint approval from FDA is the wrong endpoint, and this is why we have so many failures in this field? And also, semaglutide. I understand that we don't have GLP-1 sort of receptors in the liver, and that may be why we don't have anti-fibrotic effect. But you would expect some with that degree of weight loss and improvement of insulin resistance, that you'd get some fibrosis improvement with a very high placebo rate. Are we looking at wrong endpoint, and should we change the endpoint in this field completely?
I think the failures are just part of the success. We will look back upon them once we have one or two therapies that get approved. This is a learning process, and I think we are all learning a lot. One thing is the endpoints are not bad. The endpoints are good. I think just how we show them is tricky. And I think assessment of that and maybe modifying it and using non-invasive endpoints would be the future. And it will make the drug development more efficient. But I think, as you mentioned, if you see semaglutide, at least the phase 2B program, and then we also did a trial that was imaging based, you see improvements in a lot of biomarkers and NITs across the board. And therefore, it is, I think, my hope as well that longer term treatment and bigger trials would show improvements in fibrosis as well. And I think it's just a matter of time for us to see that. I think per se, NASH resolution or one-stage improvement in fibrosis are in the right domain. It's just that we have to use a liver biopsy to document that. If we could use, say, a 20% or 25% reduction in liver stiffness in a multimodality fashion, maybe improvements in FAST, maybe improvements in a MAS score, improvements in MAFib. And then if you have 4 different scores showing improvement, then probably the patient is improving. And how we can bring those tests to regulatory approval as a yardstick is what I think our goal is in the next couple of years.
Wonderful. Thanks, Rohit. We're going to just do some very, very quick question and answer. There are lots of fantastic questions still left, but Mazen, do you use any different cutoff for elastography if you're using M or XL probe?
No.
All right. Well, that was great. Rohit, any side effect of resmetirom? Rohit or Mazen, either one?
I think of course, side effects are listed. It's not that they're using this drug clinically. This drug is under investigation. All the side effects are being recorded. It's a thyroid hormone beta receptor agonist. We see some GI side effects, and those are being recorded. Of course, you want to make sure, although there's no inclination or any evidence, you want to make sure there's no thyroid alpha activity, which we don't see currently. So I think those are the key things to watch for. But so far, overall, the program looks very reasonable from a side effect and a tolerability profile to me.
Thanks, Rohit, and thank thank you very much to everyone who's actually logged in. There's been fantastic questions, and unfortunately we couldn't get to all of them, but we answered the vast majority, and the time is running out. So thank you very much again, Rohit, and thanks a million, Mazen, for participation. It's such a pleasure always to be with you too, and we've done a few of these in the past. And of course, thank to our audience for spending time and joining us today. We hope that information will be useful to you in your clinical practice when you take care of your own patient. If any of you or your colleagues actually missed a part of this program, it will be archived at the CMEoutfitters.com. So please, make sure that the word is out that this is, of course, is available. Also, please make sure that check out the CME Outfitter Digital Hub for more educational programs and resources. And to claim credit for this activity, please follow the directions and link on the program dashboard as you see it. So again, it's been my pleasure to participate here, and on behalf of Dr. Noureddin, Dr. Loomba, and myself, and the CME Outfitters, thank you very much. Stay safe, everyone, and good night.
Thank you very much.
Thank you. Thank you so much.